Assalamu alaikum. This is Sable and Temuri from 4th Prof RMD morning. The topic my group was given was myocardial infarction, and my subtopic was antiplatelet and anticoagulant drugs. First, I would like to get started with a brief introduction of myocardial infarction. That myocardial infarction is a medical name for a heart attack. A heart attack is a life-threatening condition that occurs when blood flow to the heart muscle is abruptly cut off, causing tissue damage. This is usually this usually occurs as a result of blockage in one or more of the coronary arteries, and this blockage can result or develop due to a buildup of plaque, which is a substance made up of fat, cholesterol, and cellular waste products. The most common symptoms of a heart attack include pressure tightness in the chest, pain in the chest, back, jaw, and other areas of the upper body that lasts more than a few minutes, and this pain usually goes away and comes back. Shortness of breath, sweating, nausea, and vomiting. An introduction to anticoagulants. Anticoagulants are drugs that help in clotting of blood or that actually help in coagulation of blood. This coagulation will occur instantaneously if a blood vessel has been damaged. Blood solidifies to help prevent blood loss and to prevent invasive substances from entering into our bloodstream. When thrombolysis occurs, whether due to the administration of a thrombolytic agent or through activation of the body's own fibrinolytic system, the fibrin clot begins to disintegrate. As the clot dissolves, there is a paradoxic increase in local thrombin generation and enhanced platelet aggregatability, which may lead to free thrombosis. Now we have classification of anticoagulants and thrombolytics and antiplatelets. Classification of anticoagulants. The anticoagulants are usually used in vivo and in vitro. The anticoagulants given in vivo can be given through parenteral route or oral route. Parenteral anticoagulants can be divided into two subclasses: indirect thrombin inhibitors and direct thrombin inhibitors. Indirect thrombin inhibitors include heparin, low molecular weight heparin, and fondaparinux. There is direct thrombin inhibitors include lapidutin and bivalirudin. The anticoagulants used in vitro include heparin, calcium complexing agents, which include sodium citrate, sodium oxalate, or sodium edetate. Classification of thrombolytics. Thrombolytics include anistriptase, which example is aminase, streptokinase, which includes streptase, tissue plasminogen activators, which includes alteplase and retaplase, and urokinase, which includes abokinase. Likewise, we have antiplatelet drugs, examples of which include abscizumab, acetyl salicylic acid, clopidogrel, dipyridamole, and ticlopidine. Now here we have some critical facts that these drugs are used to treat strokes, myocardial infarctions, pulmonary embolism, disseminated intravascular coagulation, and deep vein thrombosis. All of these conditions are potentially life-threatening. The effectiveness of thrombolytics or clotbusters is inversely related to the time that has elapsed since the thrombic crisis began, because these drugs are most effective within 6 hours of onset of symptoms. The major classes of anticoagulant drugs have distinctly different mechanisms of action, routes of administration, and adverse effects. The mechanisms of action include activation of anti-clotting factors, specifically antithrombin 3, direct inhibition of thrombin, inhibition of synthesis of blood coagulation factor precursors, for example, zymogens, and activation of protein C. The therapeutic strategies of these drugs. The therapeutic action of fibrinolytic agent is to degrade fibrinogen or fibrin threads, and their goal is to eliminate formed clots. Anticoagulants inhibit clotting mechanisms and prevent progression of thrombosis. Antiplatelet drugs interfere either with platelet adhesion and or platelet aggregation, and thus they prevent initial clot formation. Now we have a case study here that a 57-year-old man was presented to the accident and emergency unit of a local district general hospital complaining of 2 hours of central crushing chest pain radiating to the neck and shoulders. This had begun shortly after dinner and was more severe than any pain he had previously experienced. His wife explained that for the last 4 months he had been having episodes of indigestion at work, which were only partially relieved by self administered antacid preparations. The ambulance was called urgently. The past medical history included a diagnosis of hypertension 8 years earlier and a hernia repair 3 years earlier. He was also diagnosed as having a duodenal ulcer at endoscopy 2 years earlier, but this had responded well to a course of cimetidine. At the time of admission, his only relevant drug history was nifedipine, 20 milligrams twice daily. The family history included the sudden death of his father, aged 55 years, of unknown cause. It was also known that his mother was hypertensive, his elder brother had angina, and that his paternal grandmother had type 2 diabetes mellitus. He was married with 2 sons and worked as bus driver. He was a regular smoker, approximately 20 cigarettes per day, and consumed approximately 16 units of alcohol per week. On examination, he looked green and well and was sweating. There was an earlier lower segment corneal arcus. The blood pressure was 138 to 94 millimeters of mercury. Pulse was 96 and were regular, and the jugular venous pressure was not elevated. The apex beat was undisplaced, but thrusting in character, and the heart sounds were normal. The peripheries were cold to the touch, but there was no ankle edema. The foot pulses on the left were absent, and there was a femoral brute on the left. He was mildly tachypneic, but the chest was clear on auscultation. There was an old herniorrhaphy scar visible in the right groin. The lab results of the initial blood tests were hemoglobin 13.4 grams per liter, white blood cells count 7.4 exponent 9 per liter, platelets 345 exponent 9 per liter, sodium 138 millimoles per liter, potassium 4.2 millimoles per liter, urea 4.5 millimoles per liter, creatinine 95 micromoles per liter, glucose 7.6 millimoles per liter, protein kinase 160 international units per liter, and lactate dehydrogenase was found to be 580 international units per liter. The subjective, we have the chief complaint of the patient was 2 hours of central crushing chest pain that was radiating to the neck and shoulders. The patient history included for the last 4 months, he had been having episodes of indigestion at work. His past medical history included a diagnosis of hypertension 8 years earlier and a hernia repair surgery 3 years earlier. And he was also diagnosed with duodenal ulcer at endoscopy 2 years ago. The family history included a sudden death of his father of a known cause. He was 55 years of age at that time, and his mother was hypertensive. His elder brother had angina, and his paternal grandmother had type 2 diabetes mellitus. The patient was a regular smoker of cigarettes, at least approx 20 cigarettes per day, and consumed approximately 16 units of alcohol per week. Age of the patient was 57 years old, and the gender was male. Now, current or the previous medications that the patient has been or had been taking, he used to take antacids for his indigestion. He took a course of cimetidine when he was diagnosed with duodenal ulcer, and he was on nifedipine 20 milligrams twice daily when he was admitted to the hospital. Now, the objective that we have here, physical examination findings included he looked gray and unwell and was sweating. There was an early lower segment corneal arcus. The peripheries of the patient were cold to touch, and there was no ankle edema. The foot pulses on the left were absent, and there was a femoral root on the left. He was mildly tachypneic, but the chest was clear on auscultation. There was an old herniorrhaphy scar visible in the right groin. His vital signs were blood pressure 138 to 94 millimeters of mercury, pulse 96. The jugular venous pressure was not elevated. And his lab results included hemoglobin 13.4 grams per liter, white blood cells count 7.4 exponent 9 per liter, platelets 345 exponent 9 per liter, sodium 138 millimoles per liter, potassium 4.2 millimoles per liter, urea 4.5 millimoles per liter, creatinine 95 micromoles per liter, glucose 7.6 millimoles per liter, and creatine kinase 160 international units per liter. The assessment, the patient shows primary signs and symptoms of acute MI. Various risk factors such as elevated blood pressure, elevated serum triglyceride levels, smoking, obesity, and diabetes mellitus all contribute to the occurrence of myocardial infarction. The patient shows an increase in his blood pressure and he has a history of smoking and he was also alcoholic. His blood pressure is elevated and amongst the lab results, his glucose is out of the range. It should be within the range of 5.6 to 6.9 millimoles per liter, whereas his glucose in his lab report was 7.6 millimoles per liter, which is slightly elevated. So this elevation in glucose is potentially an indication of diabetes. The patient's creatine kinase is also elevated, which means that a patient has an inflammation of the heart muscle or the patient is having heart attack. Now, the plan would be the immediate concerns for a patient with suspected myocardial infarction should be their safety and comfort. Intravenous access must be available for effective administration of emergency during therapy, followed by rapid transfer of an area with a high level of supervision and resuscitation facilities. Increasing comfort of the patient includes administration of oxygen, analgesia, antiemetics, and nitrates. An ECG should be arranged rapidly. Oxygen therapy should be given to the patient within first 24 hours. Intravenous diamorphine in the dose of 2.5 to 5 milligrams should be given to subside the pain. Cyclizine 50 milligrams or metoclopramide 10 milligrams is given intravenously to provide an antiemetic effect due to diamorphine. Aspirin 160 to 325 milligrams during acute myocardial infarction, then 75 to 325 milligrams per day should be given for an indefinite period of time. An ACE inhibitor such as captopril 12 to 50 milligrams thrice a day, and then we better start with long-acting ACE inhibitors for an indefinite duration. Atenolol, which is a beta blocker, should be administered 5 milligrams IV over 5 minutes, followed by 5 milligrams IV 10 minutes later. And after second IV dose, immediately begin with 50 milligrams per oral, followed by 50 milligrams per oral 12 hours later. Elevated glucose levels of the patient should be countered by either insulin if necessary, or an oral hypoglycemic agent. Angiography should be performed to check for a possible blockade of coronary artery, and if any blockade is found, go for a subsequent angioplasty. Other than all these primary measures, heparin can also be considered for early therapy of acute MI. Since the patient is suspected to have diabetes mellitus, he must undergo for a test for HbA1c, and if he tests positive for diabetes, then a proper antidiabetic drug regimen should be started. So following are the drugs that I would recommend the patient post-myocardial infarction after he has been discharged. Aspirin, the dose of 81 milligrams per day, clopidogrel in the dose of 75 milligrams per day, lisinopril 20 milligrams per day, metoprolol 100 milligrams twice a day, atorvastatin 80 milligrams per day, nifedipine 20 milligrams twice daily, sitagliptin 100 milligrams per oral per day only if the patient is found to be diabetic. The advice that I would like to give to the patient that he should strictly follow his drug regimen and should not miss any dose. Certain lifestyle modifications such as smoking cessation, dietary modifications, aerobic exercise should also be done by the patient. The patient needs to keep a strict check on his cholesterol levels. And since he is diabetic, or then he needs to control his intake of sugars, carbohydrates, and saturated fats. So that's all. I hope I was able to convey what I had intended to. Thank you so much.